ECMO. What is ECMO? I'm going to talk about ECMO as a mean to tide the patient over a severely hypoxic crisis. You know that ECMO was rejuvenated recently by the H1N1 pandemic, particularly in Europe and Australia and New Zealand. We've been working with ECMO for many years. But what I'm going to talk today is about the use of NAVA to handle the lungs of severe ARDS patients undergoing ECMO. This is a very, very special setting, but it might teach us a few things about NAVA and about the ventilatory management. This is a slide taken from a very famous paper, now 10 years old, the famous paper of the NIH ARDS low tidal volume versus high tidal volume study. It showed that if you use a low tidal volume, 6 milliliters per kilo, survival is some 10% better than using 12 milliliters per kilo. Good. Protective ventilation increases survival. But are we at the end of the story? Well, I have doubts. If you see here the group receiving lower tidal volumes compared with the group receiving traditional, that is 12 milliliters per kilo tidal volume, and we go down to the line, to the last line, which is minute ventilation, liters per minute, you see that both low tidal volume and high tidal volumes patient have a very high minute ventilation indeed. It's paradoxical that the low tidal volume group has, in average, a higher minute ventilation than the high tidal volume group. And I don't have to explain you why. But the concept is that we might decrease the tidal volume, and that is one side of the ventilator-induced lung injury. What about minute ventilation? And that is a fact. The other fact is that ECMO, extracorporeal membrane oxygenation, is not just an oxygenator. When we start the pump, we load the blood of the patient with oxygen, but we take CO2 out. And since we know that we breathe to remove CO2, that is, if we did not have to remove CO2, we could not breathe at all. We could stand apneic, provided there is some oxygen around. We breathe air in and out to eliminate CO2. Ventilator-induced lung injury is due to the fact that we have to eliminate CO2. It's not due to the fact that we are hypoxic. Luckily, our patient is hypoxic. But keep this idea in mind. Ventilator-induced lung injury is not due to hypoxia. Ventilator-induced lung injury is due to the fact that we have to eliminate CO2. Our membrane lung gets CO2 out of blood. So when we remove CO2 from the blood, we can decrease ventilation from 100%, the basal value, down to 0 when we remove all the CO2 produced per minute. ECMO is a powerful tool to oxygenate the patient and avoid acute hypoxic death, but is also a powerful tool to remove CO2, hence is a powerful tool to avoid ventilator-induced lung injury. the previous slide was in experimental animals. This is in patients. When we increase CO2 removal, the patient decreases his own ventilation. Simple. Why I am putting this together with the RDS? This is another very famous paper from Marco Ranieri's group. This is a CT scan with strange colors. The red color indicates areas of hyperinflation, areas subjected to ventilator-induced lung injury risk. And this is an end inspiratory CT scan taken on a patient being ventilated with what we think is lung protective ventilation, 6 milliliters per kilo. There is quite a bit of red in this CT scan. It means that even with lung protective ventilation, at least 30% of ARDS patients undergo a very high risk of ventilator-induced lung injury still. So what did Marco do? He took these patients with all these red lungs, and he applied something like a hemofiltration system coupled with a membrane lung. That is a very simple machine which uses a hemofilter and a membrane lung at a blood flow lower than 400 milliliters of blood flow per minute to remove CO2. A small amount, perhaps 15 to 20% of the minute production. And as you can see, it could decrease minute ventilation down from 6 milliliters per kilo to 4 milliliters per kilo. Plateau pressure was decreased from 28 to 23. And so he could prove that by removing even a small amount of CO2, he could bring the lung back into a region with a very small chance of ventilator-induced lung injury. So what is the point? The point I want to make is that during ECMO, we are free to handle the patient's lung the way we want, according to the amount of CO2 we remove. During ECMO, there are obviously no RCTs telling us how to handle the patient's lungs. We know that in the old times, when we did randomized control studies on ECMO, if we do not change ventilation, mortality remains the same. Physiological data are scanty, so we are guided by common sense and physiological approaches. How do we do? Well, I skip the technicalities, but one thing is important. These patients are hypoxic, but we do not need to recruit their lungs anymore because oxygenation is taken care by the membrane lung. And at this point, we do not know whether a recruited lung heals faster or better than a non-recruited lung. We maintain an airway pressure, we maintain PEEP out of tradition and common sense, but we know that recruiting is a very debatable maneuver. When our patient has lobar pneumonia, we do not try to recruit this lobe. When our patient has pneumonia in 4 lobes, the patient gets intubated, and we apply PEEP to do what? To recruit lobar pneumonias? Quadrilobar pneumonias? That's what we do every day, but we do not know why, really. Perhaps just because PO2 increases a little bit. Now, what we do is to try to move the patient into once again to spontaneous breathing as soon as possible. Any role for NAVA? Well, We have heard this morning that NAVA decreases ventilator-induced lung injury. So, a severe ARDS, even during ECMO, it might be the best place to apply NAVA. And I skipped this slide that is an experimental slide by Brander showing that if we apply NAVA, interleukins and tissue factors for PA1, the analogous of TNF, is decreased when rabbits are ventilated with NAVA rather than with controlled mechanical ventilation. But the best part is the autoregulation. During NAVA, the patients maintain a lung protective tidal volume in spite of any increase in the support. And that is much better and much better doing than pressure support. Moreover, these patients, as I told you earlier, have usually a very low compliance. So they are not easily put on assisted breathing rather than controlled mechanical ventilation. The major problem is that when compliance is very low, double triggering is very common. Like in this case, when we switch this case to NAVA, the double triggering disappeared. But this is obvious with NAVA. So, are there any clinical study about the application of NAVA during ECMO? Well, I found very little data. This is a study from the group of Thomas Müller from Germany. He studied 6 patients, and he changed the blood flow of ECMO. Actually, he changed the gas flow of ECMO. Because changing the gas flow, we changed the amount of CO2 removed. And these are the individual patients, patients A, B, C, D, E, F. And you see here the EDI that increases when the CO2 removal is decreased. When we decrease CO2 removal, EDI increases. And there is a parallel increase in tidal volume. The less CO2 we remove, the higher the ventilation of the patient. As I told you, we noticed in animals, we noticed with pressure support in previous studies. We ourselves, we studied 10 patients during ECMO. The average compliance was 18. The average PEEP was 9. They were undergoing ECMO at an average blood flow of 3.2 liters per minute, which is not very high, but is not low. They had been on mechanical ventilation for 23 days and on ECMO for 19 days. We tested pressure support with expiratory cycling at 30% versus pressure support with expiratory cycling at 1% of peak inspiratory flow versus NAVA. What did we find? Well, first of all, tidal volume was maintained. PF ratio has no meaning here because the oxygenation is due to the membrane lung. PO1, we often forget about PO1, but PO1 is a very good measurement of the respiratory drive, very simple to take. Went from 3 to 1.4. 3 is not very high, is a decent value for PO1, but 1.4 is a very restful respiratory drive. Respiratory rate went down slightly to 18 from 24, but the asynchrony index dropped down from 51% to 16 plus minus 9. Mind you, these were patients with a respiratory system compliance of 18 milliliters per centimeter of water. This is the result of the asynchrony index plotted, pressure support versus NAVA in patients with very low compliance once again. And this simply shows you the change in asynchrony index from pressure support to NAVA according to the patient's compliance. That is, the change in asynchrony index, the improvement with NAVA is higher the lower the compliance of the patient. The sicker the patient, the better the effect of NAVA. So what can I tell you about NAVA during ECMO? Not much. First of all, ECMO is not an everyday procedure in every hospital. But is getting more and more common these days. I don't know what will happen in 10 years. But it's a good model for an extremely severe ARDS patient. NAVA certainly ameliorates the interaction between patient and ventilator, even in those ARDS ECMO patients. The effect of NAVA is bigger and more evident in the sickest patients. NAVA might help us go from the control mechanical ventilation paralyzed ECMO patient, this one was the first one published in 1972, to a patient spontaneously breathing during ECMO. Now in US, we have colleagues that make people walk while on ECMO. I don't know anybody in Europe that does it, but there are at least 2 or 3 groups in US that walk patients, but they pull the cart with the pump. Not, the patient does not pull the cart. And then I have a last slide for you. We know, do I have 2 minutes? We know that a major problem in this severest ARDS patient is the respiratory drive. It's very difficult to get the respiratory rate low, at least in a good percentage of them. They breathe 35, 40 times per minute, and we do not know what to do to decrease the respiratory rate. Well, when we plot EDI against PCO2, we find this kind of thing, which is not very exciting, is it? It's like a shotgun. Same is true for PO2, another shotgun. This is compliance. EDI versus compliance. Makes more sense. Perhaps I'm just lucky, 10 patients. But it makes sense. When I have more numbers, when we have more information, perhaps we might be more convincing in saying that the lower the compliance, the higher the respiratory drive. But it should come as no surprise, though. Thank you very much.
Thank you very much, Antonio. Any questions for Antonio? I think we're going to, do you have a question? Jean-Paul?
I'm trying to understand the mechanism behind the double triggering when you have low compliance, and it's unclear to me.
There are many explanations. The explanation that I prefer is that the ventilator starts with a high flow, then the compliance is very small, so the time constant is very short. The gas flow, the inspiratory flow drops suddenly, it goes down, it goes on expiratory phase, the patient still wants to inspire, then another trigger starts again. You can try to fight it either by decreasing the inspiratory flow. In the old Servo C, we decrease the working pressure. Or you can change the expiratory trigger. But when the compliance is very low, it doesn't work anyway.
Or change the tube.
Sorry?
Or change the tube.
Well, that's...
Because the tubing is so compliant.
Yeah, if you put neonatal tubes, the situation improves. Well, you know, when you have to fight with strange physiology, you try everything. And it works because the tidal volume is so small.